guideline will be available for download, and we'll provide more information about that. And what we'd like to do is just go through very briefly an overview and an introduction of the guideline. In terms of the purpose and scope of the guideline, I'd like to remind everyone that this is a new edition, a second edition of the printing of this guideline. The purpose and scope of the guideline remains similar to the first edition in that the guideline was addressed to answer the question how to assess and manage people with established diagnoses of diabetic foot ulcer. And in that case, it would be the assessment, management of current foot ulcer in patients with diabetes, but also the prevention of re-ulceration in those patients. The guideline provides evidence-based recommendations to all nurses as well as the interprofessional team who provide care in all healthcare settings to people 15 years of age and older with type 1 and or type 2 diabetes, and again, who have an established diabetic foot ulcer. In terms of the background for this guideline, current statistics demonstrate that diabetes is quite a serious and complex lifelong condition affecting currently about 8% of the world's population and nearly 3 million Canadians. We also know from the Canadian Association of Wound Care that 15% of Canadians with diabetes will develop a diabetic foot ulcer in their lifetime. The guideline was written also, of course, acknowledging the serious complications arising from diabetes, which include, in addition to ulceration and amputation, which are results from major complications such as peripheral artery disease, which we term with its acronym PAD, and neuropathy. PAD is a circulatory problem, and neuropathy is a type of nerve damage. And again, we will describe more of these details within the context of the guideline itself. It's also interesting to note that in Ontario, 50%, so half of all lower limb amputations, are directly related to diabetes. Diabetic foot infections require medical attention ranging from minor interventions, including debridement and antibiotics, to major, which may be resection and amputation. And RNAO takes the approach that care of persons with diabetic foot ulcers demands a systematic team approach from healthcare professionals, and certainly the literature supports this. And we know that nurses can facilitate and positively influence wound healing outcomes by promoting, collaborating, and participating in interprofessional healthcare teams. What I want to show you now is the pathway to diabetic foot ulcers that really serves as the framework for this guideline and our approach to addressing practice, education, and policy recommendations. And we take this pathway from a publication by Levin in 2001. And really this pathway is meant to highlight the path of diabetes through peripheral artery disease, which we spoke about a moment ago, and neuropathy, which you can see has major implications leading to ulceration, possible infection, and ultimately amputation if untreated. We know from the Canadian Association of Wound Care that it's suggested more than half of amputations may have been prevented by appropriate and effective footwear, foot and nail care. So this pathway very much shows that there is an opportunity to intervene early and effectively, and certainly our guideline addresses recommendations to that respect. Very briefly, and again, further details are provided within the guideline. I want to speak about our guideline development process. There are several steps which, in the initial stages for the literature search and screening and review, we follow systematic review methodology. And of course, the expert panel is intricately involved in all of these steps. We conduct a literature search, screening, quality appraisal, and data extraction according to systematic review methodology. We prepare a report including all of the recommendations. It's sent out for external stakeholder review, and then we proceed through to publication. Guidelines that are revisions of previous editions versus new guidelines have some differences in terms of their development. And again, within the guideline, you'll see how the expert panel is brought on initially in the early stages of the guideline to help determine and verify its scope and purpose. For this particular guideline, there were 4 major research questions that we addressed when we went to the literature looking for the highest quality evidence on this particular topic. Those 4 areas included assessment of foot ulcer in clients with diabetes, management of foot ulcers, and prevention of re-ulceration. We also examined the literature on healthcare professional education and training. And finally, healthcare organizations and optimal strategies to support and promote the assessment and management of foot ulcers and diabetes. Our search strategy, again, further details I will comment will be published in an upcoming manuscript on the systematic review for this particular guideline did include search terms and their synonyms for diabetic foot ulcer, assessment, and management. And the asterisk next to those two terms is simply a wildcard indication indicating that any suffix could follow. Again, the search strategy terms were much more comprehensive than this, but it provides a good general overview of some of the terms that we looked for. Databases included CINAHL, Medline, Embase, and several Cochrane databases, and the literature was limited to those articles published since the previous edition from 2004 through to and including 2012. The limits were also applied to the English language and, of course, to research involving humans. In terms of systematic review, and I hope that this comes through clearly on your screen, those familiar with current standards for publication of systematic review, you have followed the PRISMA guidelines. And in terms of the search results, we had nearly 6,700 articles returned from our search with our screening limits applied. And through our screening process, we had a final inclusion list of 34 studies. Again, details of that screening process and how independent reviewers were used to screen and extract and quality appraise that literature are further detailed in the guidelines. Our recommendations are graded according to their level. And this level is an adaptation of current levels offered by the SIGN group. And so you'll see that there are 6 levels there with details on each. Next to each of the recommendations, you'll see one of these levels indicated, 1A being evidence obtained from meta-analyses or systematic reviews of randomized control trials, 1B being evidence obtained from at least one randomized control trial, and progressing through to the 4th level of evidence, which is evidence obtained from expert committee reports or opinions and or clinical experiences of respected authorities. And here our expert panel really had a chance to shine in terms of identifying best practices based on their vast experience in this field. So before I pass it over to Laura to discuss the practice recommendations, I just want to provide a summary of what the guideline includes. There are 19 practice recommendations which have been divided amongst assessment, planning, implementation, and evaluation domains. There are 2 education recommendations and 5 organization and policy recommendations. I'll now pass it over to Laura to detail for you some of the practice recommendations included in the guidelines.
Thank you very much. Thank you very much, and welcome everyone this afternoon. I'm very pleased to be presenting the practice recommendations that the panel was able to revise over the past few months. We're starting with wound bed preparation paradigm that has been is probably well known to most people in the wound care community. This particular paradigm addresses the diabetic foot ulcer. So in the pink box, we think about treating the cause of the ulcer, and that is in the case of diabetes, looking for vascular insufficiency, infection, and pressure. We also think about managing patients' comorbidities related to diabetes as well as other comorbidities. On the right-hand box, we are also concerned about patient-centered concerns. So we are thinking about, I'm sorry, can I just have the bigger, there we go. Providing an individualized patient education program, engaging patients and family in care planning, exploring potential barriers to adherence. And then we move down to the local wound care. And this involves debridement of non-viable tissue, addressing infection or inflammation, ruling out and treating localized or spreading infection, providing moisture balance, which means a moist, interactive wound environment if the wound is healable. And by treating the cause, we're looking at addressing vascular insufficiency, infection, and pressure. And we explore barriers to adherence if the local wound care is not working. And if all of these interventions are in place and our patient is not progressing, then we would consider using biological agents and adjunctive therapies. So this is the framework that helped us to craft the practice recommendations. The first recommendation is to obtain a comprehensive history and perform a physical examination of all affected limbs. The second recommendation, 1.1, is identifying the location and classification of foot ulcers, including measuring the length, width, and depth of the wound bed. 1.2 is assessing the bed of the foot ulcer for exudate, odor, condition of the peri-ulcer skin, and pain. 1.3, assess affected limbs for vascular supply and facilitate appropriate diagnostic testing as indicated. 1.4, assess foot ulcers for infection using clinical assessment techniques based on signs and symptoms and facilitate appropriate diagnostic testing as indicated. 1.5, assess the limb for sensory, autonomic, and motor changes. 1.6, assess the affected limb for elevation of foot pressure, structural deformities, ability to exercise, gait abnormality, and ill-fitting shoe wear and offloading devices. 1.7, document characteristics of foot ulcers after each assessment, including the location, classification, and any abnormal findings. Recommendation number 2, determine the potential of the foot ulcer to heal and ensure interventions to optimize healing have been explored. 2.1, develop a plan of care which incorporates the goals mutually agreed upon by the client and the healthcare professions to manage diabetic foot ulcers. This particular recommendation was a lively conversation with the panelists, and we felt that recommendations that our healthcare professionals made have to be in congruence with what the patient is able to comply with, as well as what their own goals are, and exploration of people's beliefs, their belief systems, and what they are capable of participating in were very important. 2.2, collaborate with the client or family and interprofessional team to explore other treatment options if healing has not occurred at the expected rate. 2.3, collaborate with the client, family, and the interprofessional team to establish mutually agreed upon goals to improve quality of life if factors affecting poor wound healing have been addressed and complete wound closure is unlikely. 3.0, implement a plan of care to mitigate risk factors that can influence wound healing. And this addresses management of diabetes as a disease. We again had very lively conversation around diabetes disease management as one of the major risk factors for protracted wound healing. 3.1, provide wound care consisting of debridement, infection control, and moisture balance where appropriate. 3.2, redistribute pressure applied to the foot ulcer by use of offloading devices. I believe that this is probably one of the most important practice recommendations that we struggle with in nursing, but as in treating diabetic foot ulcers as a whole. And this will be one of the major barriers to care for our patients in the future. 3.3, provide health education to optimize diabetes management, foot care, and ulcer care. 3.4, facilitate client-centered learning based on individual needs to prevent or reduce complications. 4.0, Monitor the progress of wound healing on an ongoing basis using a consistent tool and evaluate the percentage of wound closure at 4 weeks. 4.1, reassess for additional correctable factors if healing does not occur at the expected rate.
Great, thank you, Laura. It's Monique Lloyd speaking again, and what I wanted to do as well is just highlight that, of course, while many further details are provided in the guideline around these recommendations in terms of their meaning and their implementation in practice, something else that the RNAO has done, of course, we have published many guidelines. And in terms of some of the practice recommendations that you heard about facilitating client-centered learning and as well client-centered care, we certainly have supplemental guidelines that would assist with those particular recommendations and have guided the reader to those particular resources where they exist. In particular, as I mentioned, we do have a facilitating client-centered learning guideline that was recently published, and as well a client-centered care best practice guideline that will assist with some of the recommendations in the planning phase. I'll now take you through the education recommendations, of which there are 2, and really they're quite closely linked. 5.0 speaks to healthcare professionals participating in continuing education opportunities to enhance their knowledge and skills, to competently assess and manage clients with diabetic foot ulcers. It follows in 5.1 that educational institutions, and those geared to nurses as well as physicians and interprofessionals, incorporate the RNAO guideline into their basic education programs. The panel has decided that the knowledge and skills necessary for the assessment and management of diabetic foot ulcers, of course, are key in terms of obtaining quality outcomes in this particular area. And often in entry-level programs, that type of education is not provided. And education recommendation 5.1 really arises from that, or sorry, 5.0. And 5.1 speaks to the need to begin thinking about incorporating more comprehensive training at the undergraduate level in interprofessional healthcare curriculum. Our final area of recommendations are the organization and policy recommendations, of which we have 5. 6.0 speaks to using a systematic approach to implement the RNAO guideline and provide resources and organizational and administrative supports to facilitate clinician uptake. And what we'll do following the presentation of these organization and policy recommendations is speak a bit to the importance of an implementation strategy for this guideline, which will also touch on some of the resources available to enhance implementation of 6.0. In 6.1, the panel has developed a recommendation around developing policies that acknowledge and designate human, material, and fiscal resources to support the interprofessional team in diabetic foot ulcer management. That recommendation following the previous recommendation in terms of what is needed in order to effectively implement the guideline and provide effective assessment and management of foot ulcer care. The third recommendation, that's recommendation 6.2 in the organization and policy section, speaks about establishing and supporting an interprofessional interagency team comprised of knowledgeable and interested persons to address and monitor quality improvement in the management of diabetic foot ulcers. And in the guideline itself, it provides a list of those types of professionals and who may be interested and knowledgeable in terms of participating on the team for effective care delivery. 6.3 speaks to developing processes to facilitate the referral of clients with diabetic foot ulcers to local diabetes resources and healthcare professionals, and in particular speaking about the importance of the availability and accessibility to community-based resources in enabling the continuing care of clients with diabetes with diabetic foot ulcers. Our final organization and policy recommendation focuses on advocating for strategies and ongoing funding to assist clients in obtaining appropriate pressure redistribution devices during and after ulcer closure. And this very much was singled out by the panel for its significance and impact in the care of foot ulcers in people with diabetes. And again, the idea of pressure redistribution being echoed in many of the practice recommendations as an imperative strategy for foot ulcer care clients with diabetes. So that summarizes the recommendations contained within the guideline, and what I'd like to do now is pass it over to Dr. Imogen Zainok, who will speak to some strategies and tools for guideline implementation.
Thank you very much. And one of the things I will start this section with is to say that you can see how we have a very rigorous guideline development process, and in addition, we pay as much attention to implementation. Both the education and the organizational and policy recommendations really address that notion of implementation and how we support both the practitioner as well as the organization to enable full uptake of these kinds of recommendations for practice. In terms of the implementation, we have learned over our 14 years of work in the BPG development and implementation area that guideline implementation of care is both multifaceted and challenging. We need to focus on knowledge transfer. We need to focus on clear and consistent practice changes. We need to focus on sustained focus on use of the guideline and measurement over time. We've learned that the uptake of knowledge in any practice setting requires much more than the awareness raising and distribution of the guideline. Certainly this is why we recommend that you look to some of the resources RNAO has developed over the years. The one that's been most useful across the province and indeed around the world is the RNAO Toolkit Implementation of Best Practice Guidelines. The second edition has just been published last year, and it provides an evidence-informed process for a systematic and well-planned implementation, taking us all the way from the need for the guideline to the notion of evaluation. We will be really referring very much in depth to that resource as we have our implementation webinar a week from today, and that will be on Tuesday, March the 26th from 12 to 1 p.m. I do want to also say that while that toolkit is a key implementation strategy, we have a number of other very creative implementation resources that we use. One is the Champion Network, whereby we prepare champions across all settings to learn about guidelines, evidence-based practice, and indeed the whole process of knowledge transfer. In addition, at the organization level, we have what we call best practice spotlight organizations. This, in fact, has enabled organizations to partner with RNAO to implement multiple best practice guidelines across their settings. And through this process, we introduce them to and support them through a systematic process whereby their organization develops a methodology for guideline implementation, sustained use, and evaluation. And we'll talk much more about this at the implementation webinar. And then the last strategy that we use is focused on learning in an in-depth way. And this is our series of institutes, which are week-long learning events whereby teams of nurses from organizations attend to learn the process of guideline implementation in a general or in a more specific content area. So I will mention that what we will be focusing on next session is how each of these strategies can be used in your organization interprofessionally with staff from all professions to really aid in guideline uptake and implementation. I do want to say before I turn things over to the question and answer session that this process we've discussed today is a process that RNAO uses in all guidelines that are developed. We have been working with the guideline development program since 1999, so some 14 years. We have developed 47 clinical and healthy work environment best practice guidelines, and use and keep refining the rigorous development process, and as well adding to the basket of resources and strategies for enhanced implementation. So having said that, I will see if any other member of the team here wants to make a comment, and then open for question and answer.
Perhaps meanwhile that people are sending a comment, and I already see one, if people can get the PowerPoint. Absolutely yes, you can get the PowerPoint and we will send it to you. What I want to comment is how the guidelines of RNAO are similar or different than other guidelines around the world. They are similar to those that follow a rigorous scientific approach to guideline development with all the conventional criteria for guideline development. So in that way, there are similarities. They are different in the sense that RNAO guidelines not only include the clinical recommendations, which are critical, but also the education and the organizational and policy recommendations that both Monique and Irma-Jean just mentioned. And those have been critical aspects of the success and critical aspects on the success on uptake of guidelines. The other piece that is absolutely necessary in guidelines, and that perhaps not all organizations can follow in such a rigorous way, is the cyclical way in which we revise our guidelines. We review and revise as necessary guidelines. So we do have a cycle of every 4 years of a full revision of the guidelines, and hence why you are seeing now the wonderful work of our colleagues in the second edition of the foot ulcer guideline. It is an honor for us that the Council of Federation selected this guideline, and it was also an honor to respond to their idea that we actually offer a seminar through webinar, both one today in the guideline development, as well as next week on the how to go about implementation of guidelines. Because whether it's this guideline or another one, if we only will stay with a well-developed guideline but not put it to use through the hands, hearts, and minds of all healthcare professionals, and these guidelines are applicable to all, then it will be really to the detriment of our patients. The last thing, and we are not touching this week, but probably next week, yes, is that we are developing order sets related to these guidelines, and that will be touched next time.
Okay. As we move into the question-answer period, I will just have Dr. Lloyd review for you how to ask a question. There's a couple of different ways, and you need to get it right.
Thank you, Irma-Jean. So certainly we'd like to have a bit of an interactive dialogue, not only with yourself, but also because we have the wonderful opportunity to have Laura Teague here as well, the chair of the expert panel. And so what I'd like to do before we begin is just alert you there were 2 ways for you to connect to this WebEx presentation. One was to not have the ability to use a microphone, and in which case you'll need to use the chat box, which you'll notice in the bottom right-hand side of your screen. So feel free to type in your questions there, and we are monitoring those, and we'll address as many of those as we are able. If you were able to connect with a headset, we do have the audience on mute at this point in time, but if you have a question you would like to ask, please raise your hand, and you'll notice the icon for that just above the chat box, about midway on the page on the right-hand side. When we see your hand raised, we will unmute you and alert you that we'd love to hear your question, and then certainly we'll address it from there. And as well, we will, I'm sure, engage in some dialogue with Laura a bit further about some of the practice recommendations, and I'll let Irma-Jean facilitate this particular session.
Very good. Thank you, Monique, and thank you for reinforcing that there is time for further discussion of the practice recommendations. But we do see a first question here that is asking for the expertise and practice backgrounds of the members of the expert panel. And I'll ask Laura to share that information, Laura Teague, and maybe talk a little bit about the stakeholders as well.
Thank you, and it was my pleasure to work with the expert panel for the revision process. I won't go through individuals' names, but I'll just let you know that we were very careful to invite other disciplines to the table for this panel revision. We had a professional practice leader from a rural hospital. We had a wound care specialist and clinical trials coordinator from Dr. Gary Sibbald's office in Mississauga. We had an advanced practice nurse and educator from the Toronto Regional Wound Healing Clinics. We had an intrastomal therapy nurse who is currently working on her PhD at the University of Western Ontario. We had a diabetes educator. We had a physical therapist who is master's prepared at wound healing from University of Western Ontario. And we had a chiropodist who also has a master's degree in wound healing from the Ottawa Hospital. Myself, I am a nurse practitioner, and I'm a lecturer at the University of Toronto Faculty of Nursing, and I'm also an adjunctive faculty member at Western University in the Faculty of Physical Therapy, Master of Clinical Science in Wound Healing in Toronto. And I work in Toronto at St. Michael's Hospital. From a stakeholder perspective, we asked many different experts from around the world as well.
You may want to explain when the stakeholders come to play.
Oh,
because
sure.
People are not familiar with the process.
Absolutely. So after we had our semi-final draft of the recommendations crafted, this text was sent to stakeholders for review. And we had people from the University of Arizona College of Medicine, Women's College Hospital, Dr. Keith Bowering from Edmonton, Alberta, Dr. Tim Brandeis from the Ottawa Hospital, Connie Harris, who is an RN and ET and has a Master of Science and is a clinical specialist in wound and ostomy care in Waterloo, Ontario, Janet Kuhn, who is a PhD candidate and is working for St. Elizabeth Healthcare in Cornwall, Ontario, Anne Marie McLaren, who is a master's prepared podiatrist, chiropodist, and professional practice leader at St. Michael's Hospital, Stephen Mostowi, who is a vascular surgeon in Kelowna, BC, Lindsay Orr, who is a physical therapist and also has a master's degree in wound healing from Cambridge, Ontario, Cynthia Payne, registered dietitian, Dr. Gary Rose from the University of Ottawa, Ottawa Hospital in infectious diseases, and Jenny St. Jean, who is a Bachelor of Science in Nursing and a wound care champion at Bayshore Home Health in Ottawa. So you will see that we had a very broad spectrum of stakeholders from not only Canada but across North America, who provided us with excellent feedback, and we took their recommendations very seriously and incorporated them into the final draft of the document.
Thank you very much, Laura. And again, please state your questions. I will move to the next question. And thank you. That was very helpful according to the questioner. Thank you, Laura.
Congratulations.
Yes, and congratulations. Yes, thank you. Now, there was a question, and as Doris already gave notice to, we will be talking more about nursing order sets as a support to implementation. But question is saying, when will the order sets be out for this guideline? And as you can appreciate, so this revision is hot off the press, and we are anticipating that the order sets for this guideline will be completed in May. So stay tuned for that. But Rita Wilson, who is our lead in order set development, will be part of our session next Tuesday when we're talking about implementation. Now, there's a next question here, which says, awesome work. There's a real lack of offloading support for our patients. Do you have any suggestions for accessing this care or tackling this issue? And certainly I would say the guideline has considerable information on that. I'll ask Laura if she might want to highlight some areas briefly for us. And just before that, you can see here that you can download the guideline free of charge from the RNAO website.
You asked the million-dollar question, whoever Susan is, and thanks for asking that question. This is a major struggle for every organization in Canada, I can imagine. Offloading, to me, is the #1 most important intervention and is the most difficult to access. We don't have any answers for this at this point, but my hope is that when this guideline goes back to the Council of Federation, that particular issue is brought up as one of the major barriers to implementing the guideline from a national level, and maybe with some pressure from the RNAO, there will be some leverage around getting some funding access for these particular devices. I think everyone that's on this call will agree with you that offloading is the most difficult intervention to be able to access for our clients.
Thank you, Laura. And I would add to that not only intervention by RNAO, but really by a national voice, I think would really make an impact. Are there other questions or comments that would assist you better understand the guideline and know how best to begin to use it? While you may be thinking of questions, I might just turn again to Laura to see if there are any areas in the assessment, planning, intervention recommendations that you might want to highlight as key aspects of the guideline, or areas that you feel you'd want to highlight as having great clinical relevance.
Thank you, Irma-Jean. I think that one of the VIPS an acronym is important. From a vascular supply point of view, we in the past felt that peripheral arterial disease was not as prevalent as it is now. And in the literature, we're discovering that up to 50% of patients that have diabetic foot ulcers also have significant peripheral arterial disease. And that really helps us to understand maybe better why some of our patients are not doing as well as they should be. And it also makes it important for us to ensure that an appropriate vascular assessment is done. And that is not just including finding pulses, but we may have to dig a little bit deeper and get more diagnostic testing done before we decide that the person has a healable ulcer. From an infection perspective, infection is very complicated. And from my own experience working in a multidisciplinary clinic setting, we often consult with our infectious disease colleagues to help us to navigate through the sea of the many organisms that grow in patients that have diabetic foot ulcers. And so, from my perspective, working with interdisciplinary colleagues, not just other health professions, but with our various physician colleagues is really important. And then from a pressure offloading standpoint, again, my experience working with my chiropody colleagues at my own organization and with some of our orthopedic surgeons has made me much more aware of the importance of correcting or offloading high pressure areas on the foot. our success with wound healing in my own practice has been excellent, and I believe that this is because of the combination of all expertise being brought to the patient's foot at the same time, so that we come up with a plan that is coordinated and makes sense to the patient, and one that a patient is able to execute for themselves as well.
Thank you very much, Laura. I would just say that there has been a second question about order sets, and what I would say is please feel free to tune in to our session next week, where we will talk more about that, and Rita Wilson will be available to give further information. And now I just want to turn to another question that says, how did you choose the PRISMA guideline? At CDHA, we're going to start using the NICE guideline, but the document's large and complicated, and some feedback on PRISMA. And I'll turn that over to Dr. Lloyd for an answer.
Thank you, Jean. So in terms of PRISMA, for those on the webinar that aren't familiar with it, it's an acronym that stands for Preferred Reporting Items for Systematic Reviews and Meta-Analyses. And really, in our consideration of methods to use to report the results of our systematic reviews, and in particular PRISMA, we found very helpful for the flow diagram for how we obtained our articles for searching and how we screened those down to a set of included articles for consideration in this particular guideline. Of course, when we do a search, it's extremely comprehensive, and I will say that the return of 6,800 articles for this particular guideline was actually very much welcome by our research team, as often we are 10,000 articles plus. And what we find with PRISMA is it very much helps us to organize the information in a very systematic, standard way. Now, I say that with the caveat, RNAO was recently joined as a member of the Guidelines International Network group, and we know they're very much pushing to look at developed international standards for guideline development, of which none currently exist, but there's certainly a member of experts coming together, of which RNAO now is very excited to be part of, to look at how our guidelines, or how should they be standardized in terms of their reporting, and in particular the systematic review or literature review piece that informs that work. And certainly we find the PRISMA work very, very user-friendly in that respect for our purposes. Again, condensing that information down to a systematic and standardized way for reporting that's user-friendly, not only for us as we try to follow those standards, but also in terms of reporting it to our audience. And I'll just repeat what PRISMA stands for. It stands for the Preferred Reporting Items for Systematic Reviews and Meta-Analyses. The group has its own website, and various authors have published in various journals. We use publication of 2009 in the British Medical Journal as an example of this work, and it provides reporting templates for systematic reviews, and again for condensing the screening of articles. So very much we've considered NICE, we've considered some of the other groups out there, SIGN. Again, PRISMA was really the decision that best fit our needs, both from our operational standpoint, but also for interpretability by our reading audiences.
Okay, thank you very much. I'm just looking to see if there are any further questions. I do want to make sure that you're aware that the next webinar that will focus on implementation, and we'll look at not only the toolkit, but our champion network, the Spotlight Organization Program, Institute, and as well order sets, will be held on Tuesday, March 26th from 12 to 1 p.m. Eastern Standard Time. And in the information that goes out, we'll certainly clarify what time that might be in your area. Now, before we close the session, I do want to turn things back to George Johnson to talk a little bit about the CoF initiative and give the background so that you can really have a good understanding of the impact of this kind of work across this country and how it can really serve to enhance the quality of health care across the nation. Doris.
So first of all, I'm not sure that we had the opportunity for Susan Williams, the ADM of Alberta, or Basanti Srinivasa from the ADM from Ontario to join us. I know that they were going to try to join to bring readings as the lead ADMs for the Council of the Federation Clinical Practice Guidelines Initiative to the webinar, because we do know that we have between 150 and 200 participants. We will know the numbers probably in a couple of days when we get them from the agency that does this webinar. WebEx. Okay, from WebEx we will get the real figures. But we do know from the registrants that we have participation from absolutely all the provinces and territories across the country. So that is absolutely fabulous. Before I move into the Council of Federation and how the work connects, I do want to invite you on behalf of RNAO to actually visit our website at www.rnao.ca, again, www.rnao.ca, so that you can visit not only this new guideline that will be posted immediately after this session, but also all the other guidelines that are available free of charge at your disposal. And many of those guidelines have also support tools for implementation in addition to the toolkit that Irma-Jean mentioned. I also want to invite you to consider joining the journey, so to speak, in a more formal way. And I know my colleagues will speak with you about the various implementation strategies at next week's seminar, including some of the ones that Irma-Jean briefly mentioned today. But just to share with you a bit of the excitement, and as an example, we are heading from here today actually to the Hyatt to meet with our 15 best practice guidelines spotlight organizations that are from across Ontario. And Minister Matthews is joining tomorrow at 8 in the morning to thank them for the tremendous concerted work that they're doing in their organizations. BPSOs, just to share with you, are organizations that commit to the implementation of evidence-based guidelines through a very formal agreement with RNAO. No, it will not cost money, but I always say it will cost a lot of work, but it also will provide a lot of outcomes and a lot of satisfaction to any healthcare professional that is committed to excellence in patient care. So we invite, whether you are from an association or from a government or from a healthcare organization in any jurisdiction in Canada, to connect with us at RNAO. And if you're interested in a more formal partnership, not only in relationship to the Council of Federation guidelines that have been selected, like the foot ulcer for people with diabetes, but others that we can support you in moving in that journey. As it relates to the Council of Federation, first of all, let me acknowledge the work of Basanti and the work of Susan, the two ADMs, and of their support staff, Louis Dimitropoulos, who have done amazing work in leading this initiative forward, and who have brought together a group of associations and leaders within those associations, and I mentioned them before, HIL, CNA, CMA, RNAO, to really put their heads together, or put our heads together, to do what's best for the country. And so first, kudos to the premiers of this country that actually saw fit to focus on the area of clinical practice guidelines, and second, to their support staff within the various jurisdictions that are actually making this work happen in reality. So with that, I would want to thank you very much. I want to thank Laura that led this tremendous work and all the panelists that were involved. I want to thank Dr. Monique Lloyd, and I want to thank Andrea staff that actually have worked with several staff at RNAO to put the thrust of the panel into an actual guideline. Rita Wilson will speak next week also about the Ulcers, who's working very hard on that. And of course, Dr. Irma Bainov, who is the director of the RNAO International Affairs and Best Practice Guidelines Center. And to all of you for participating, for being intrigued, for being eager to make a difference in the life of patients and the public in general. So thank you very much on behalf of RNAO, and if I can, by extension, also on behalf of the Council of Federations and CoF, to all of you for your active participation, your questions, and your thoughts. And we are just one email or one phone call away. Feel free to connect with us at any time. Thank you very much.